Welcome to part 3 in these lectures on motivation and motivation counseling. In this lecture, I'm going to start off talking about competency support, one of the other basic psychological needs in self-determination theory. I'm going to include in this lecture description of how one can support our patients' self-efficacy beliefs. And the reason for that is that competency and self-efficacy are very similar concepts. As a matter of fact, you'll see many authors seemingly using these terms in an interrelated way as synonyms. I don't think they're exactly the same, but I don't think we really need to get into the philosophy, so to speak, of how they might be different. But one thing is clear to me anyways, and that is one can have a good self-efficacy belief that one can accomplish a task, but that task does not, if one does it successfully, does not satisfy the need for competency. Because I think the need for competency also includes this sense that the need is only met when we meet a challenge that's somehow important to us. And if a task is not important to us, again, it might still be somewhat challenging. We can have self-efficacy beliefs around it, but again, if achieving that or being supported to achieve it, if the activity isn't that meaningful, then I don't think competency is supported. Here's an overview of the areas I'm going to talk about with competency support. So I'll go over each one of them individually. What I'll say is that very much a lot of the things I'm going to talk about here in this section are things that I think speech pathologists normally do at one time or another. I think that one of the main things that is different when we're guided by self-determination theory, for example, is that we can do all of these competency supporting behaviors in controlling ways. And so when we talk about competency support, we have to remember we also need to pay attention to how we support. And of course, we want to do it in autonomy supportive ways. We'll start off with education, because I think in some ways, at least in rehab, it all starts with education. I like this quote from Hirsch and colleagues, aphasia researchers from Australia, who say, "It's not enough for shared goal setting simply to ask people what they want to work on or to invite them into a meeting. They may be too overwhelmed by everything that has happened to them and too unfamiliar with the process and expectations of rehabilitation to answer that question. Clients need to be oriented as if to a new job." So in various studies, and are there some references here, I think what is clear is that we assume that it seems self-evident to us when people enter into rehab or start therapy with us that it will be clear what they need to do. But patients don't often feel that way. They aren't confident that they know how to be good patients. And so in the goal-setting literature, the client-centered goal-sharing literature, the literature on shared decision-making, we see over and over patients expressing the desire to participate in some, collaborative care, but not feeling like they understand the process enough to feel confident that they can participate in goal setting or something like that. So in my experience, education is really important, and it's something that we don't just do once. We, in one way or another, have to educate our clients over and over again, maybe about usually about the same topics. But I think that's kind of normal. It takes people a while to understand some concepts that are very new to them. Even, I think, understanding what aphasia is. Let's say we'll talk about aphasia. That's my experience. I'm not surprised anymore, but very commonly when I get outpatients, they've been seen either as an inpatient, both as an inpatient, or as an inpatient, or both inpatient and outpatient with another therapist. When I ask them if they feel confident that they know what aphasia is, I think more often than not people say no. And so that is just one example of maybe that we don't do as much education as we could. And of course, when I go to lengths to help people really understand their condition, the feedback I've always gotten from them is this: they're quite satisfied with me having done that. The next section, the next way we support competency is by providing structure. And structure refers to how organized therapy is, whether or not there is a clear plan for therapy, that the patients are aware of that plan, they understand the plan. When people have a sense that they know why they're doing what they're doing, they know what to expect is coming up in the future, they know what is expected of them, then it's easier for them to feel confident that they can do it. I think oftentimes our clients have a vague sense of what they really need to do, or their experience is of being kind of knowing what they need to do, but not real confident that they do. And again, this can go through everything. I see it, for example, a lot with clients who are given apps, treatment apps on an iPad, for example. Showing a patient how to use an app once is, in my experience, not enough to support structure and need for competence. We need to train them over and over, really walk them through the steps, maybe do some kind of fading support, things that we normally do, right? That's structure. So we want people to feel really well supported in achieving their goals, and clear and understandable feedback, and I'll talk much more about feedback in detail in a little bit, is also part of that structure. With children, I think one of the things that might be different is with children we do have to do some limit setting, rules for behavior, etc. Of course, we talked about in autonomy support that when we are providing limits and rules, we want to provide them in an autonomy supportive way, which is providing a rationale, acknowledging that how the child might feel about that, not using controlling language. The twist here that relates to structure is we need to be consistent with applying limits and applying the rules. Then children know what to expect. I think also that the things that we can do to support conversation within a session is very much in line with competency support and providing structure. My patients with severe aphasia, without using techniques like supported conversation, are not going to feel confident that they A, understand the instructions that I'm giving them, or B, express their choice when decisions are when they're given options. The provision of AAC would be another example of supporting that we satisfy clients' needs for competency in their ability to be collaborative, be part of a working alliance. They need to feel that they can communicate in order to do that. The next way we can support the need for competence is by providing optimally challenging tasks and goals for our clients. And in general, optimally challenge means not too easy and not too difficult. So, according to Ryan and Deasy, optimally challenging tasks are tasks that provide people with challenge, but they can be successful most of the time. Occasionally, we want to incorporate some opportunities for people to push the envelopes of their ability, and in doing so, that can be quite motivating. When I think about optimal challenge, I think of games. We are kind of naturally drawn towards games that give us the right amount of challenge. So we do seem to be kind of instinctually drawn towards this concept of optimal challenge. Locke and Latham, two psychologists and co-authors of goal-setting theory, which is one of the more cited, discussed theories in the goal-setting literature and rehabilitation, and a theory that discusses motivation and the nature of goals. In other words, what goal characteristics are most motivating. One of the characteristics they describe is goals need to be perceived as being challenging. And in this theory, they think that goals that are perceived to be challenging kind of tend to naturally engage people's heightened attention and effort and persistence. Of course, the question is, what exactly is optimally challenging, or how do we find optimally challenging when we're thinking about tasks and goals for our clients? Surprisingly, not a lot has been written about how you determine what is optimally challenging. Authors just kind of seem to gloss over that part. Basically, you find two approaches towards setting optimally challenging goals. One is where we decide that some percentage over a patient's baseline is optimally challenging. Gaugal and colleagues did this in a couple studies where they looked at the influence of optimally challenging tasks, and they measured their subject's baseline performance, and then simply said that 20% above that was optimally challenging. My preferred method, described by West and Yasuda, is to simply ask our patients, what is optimally challenging? In a number of different studies, many of them in the gaming literature, one study with children shows that when given a choice, people naturally choose what is optimally challenging for them and seem to be accurate in those choices. So, for example, the one study I'm thinking about with children, they were given assessments to understand their ability to do categorization and classification tasks. And after that was assessed, they were let loose in a room with a few tables with different classification, categorization, like games and tasks of different difficulty levels. And what the researchers found was that kids naturally gravitated towards the tables that was in line with their abilities, but not too easy. Gaming studies will often use some kind of algorithm which will, based on a person's performance, will choose the difficulty level of the next task. And those studies also suggest that people, when left to their own devices, don't choose super easy and don't choose super hard. There's a couple studies in the aphasia literature looking at errorless treatments, naming treatments. So an errorful treatment is the standard, the simplest being, I show you a picture of an object, you try and name it. If you can't name it, I give you a queuing hierarchy until you can say it. Errorless would mean just simply showing you the picture and saying, dog. Can you say dog? And errorless treatment has been shown to be effective. In one paper in particular by Conroy, the authors talked to the subjects afterwards about what they thought about being in an errorless treatment. And they commented that the people with severe aphasia, the subjects with severe aphasia, loved it. They preferred that errorless approach to the more traditional errorful approach. But the subjects who had a much more mild aphasia did not like the errorless approach. It was deemed to be boring. And so here we see kind of indirect examples of how patients, if we ask them what they want and what they like challenge-wise, then we are both supporting their need for autonomy by giving them choice. We're engaging them in some reflection related to what they think they can do. That's never a bad thing. And then, of course, we might be more likely to find something that is genuinely optimally challenging. The next and very important way, I think, for supporting competency is to take a look at barriers. What are the barriers towards doing your home practice regularly? What are the barriers towards using the strategy that we've been working on out there in the real world? What are the barriers to you being in a more social situation amongst strangers, even though you have aphasia? What are the barriers, etc.? We could go on and on. There is, in the health behavior change literature, a concept called the intention behavior gap. And the intention behavior gap is a simple description of the fact that oftentimes people want to do some behavior, but they don't ever seem to get around to doing it. So, for example, they may want to exercise and exercise regularly, but they rarely get around to exercising. They may want to change their diet, but they don't get around to doing it. They may want to study more, study better, etc., but don't get around to making those changes. So hence the intention behavior gap. We've all had experiences with that state. When we look at the literature and how best to deal with the intention behavior gap, one of the more effective methods, and I think a method that fits well in what we can do in treatment, is to simply ask our patients, what do they think are the barriers? What do they predict? Ideally, we want to talk to people about what they think the barriers are to, let's say, doing their home practice, right? Let's say I just got a patient, I've assessed them, I've got a treatment plan, and now I have made some treatment materials. I'm going to give it to them. We're going to talk about a home practice schedule. I want to ask my patient what they think the barriers are. Right? In general, what I do is something like this. We've got the treatment plan. We know what that looks like. And then we decided on a goal, something that my patient wants to achieve within a certain time frame. With my adults, I ask them, okay, great. How often do you think you'll need to practice to achieve that goal? Simple question, but I think it really gets people starting to think in realistic ways. And then with some guidance, we'll come up with the amount, the frequency of practice. And then I'll say, okay, great. What do you think might be some of the barriers that will show up that might prevent you from practicing 5 days a week, twice a day, or whatever? And guide patients and encourage them to elaborate and name as many barriers as they can. And I'll say, okay, can you rank order which of these barriers that you mentioned are you most likely to experience and will be most disruptive? And then form kind of a hierarchy there. And then the final step is, okay, let's talk about what do you think you can do to manage this barrier. Okay. In my book chapter, I talk about this, and in the case study I provided in there, I talked about patient who'd been discharged from therapy in his previous therapist for not doing his home practice and being judged as not being motivated. He was concerned about whether he would be able to do his home practice regularly with me. We identified barriers, and the barriers were he had chronic pain, and so that got in the way. He was experiencing still a lot of post-stroke fatigue, and that was a barrier. And then I believe the third one was knowing how to operate the iPad and app. Anyways, so for the two most important barriers, it was as simple as us talking about it and him coming up with the solution of scheduling his practice sessions during those times when he is both typically in the least amount of pain, and B, when he typically has the most exercise. And that happened to be about an hour after he took his morning pain medication. So we can see how engaging our patients in a reflection about their barriers is in line with what we talked about with autonomy support. And it's not just, I think, that removing in a preventative way, helping people feel confident that they can meet the challenges that might be disruptive. That alone will help people feel more confident and satisfy their need for competency. But also, I think we're giving our patients the experience of solving their own problems and managing their rehab and their disability from their own abilities, which is, in the long term, a very good thing. We want also to help our patients notice the improvements that they're making. That will help to satisfy their need for competency. I think along with that is some work to help them appreciate the small gains that they make. Of course, patients need to understand what is the expected rate of recovery and improvement. It's different for different conditions and at different points in time. Right after a stroke, we might expect some rapid recovery, but quickly thereafter, recovery slows down quite a bit. And unfortunately, I would say that that improvement is often so slow and gradual that it's quite hard for patients to experience it and notice it. I use the image with my patients of walking on the beach on a foggy morning for a few miles, coming home, taking off your jacket and realizing that your jacket is soaking wet. The accumulation of moisture happened so gradually that you didn't really know that it was happening until something happened, i.e. you took off your coat, that helped you appreciate those improvements. And so that's true for my patients. One of the more common ways that they get that they've made improvements is when they see somebody they haven't seen for a few months and the person comments that they seem much better. We can do things besides relying on those kinds of experiences to help our patients appreciate that they've made improvement. Good data collection, I think, is part of that, and I'll show you a graph as an example of that on the next slide. I think another thing to consider here is number one is asking a patient a simple question like, how will you know when you're improving? What would be a sign that you could think of that you are improving? Sometimes our patients will be something like, give us, well, I'll just be able to say what I want to say. I'm like, okay, well, that's That's the long-term goal. What are some of the first signs? Well, what do you think might be one of the first signs that you would notice, the very beginning, suggests that you're getting better? And I think that really helps to focus our patients' attention away from these kind of long-term, big picture outcomes, performance-oriented outcomes, and something a little bit more near-term. Locke and Latham, goal-setting theory, say that in general, very short-term goals are more motivating than long-term goals, for the simple reason that when we think that something will come to pass sooner, there's heightened expectation. And heightened expectation increases motivation. Here's an example of a graph from one of my patients engaged in a naming treatment. And here you can see I've taken a few baseline measures to establish a stable baseline. Started treatment on one vocabulary set and probed the untreated set. He made improvements on the treated set, and then I introduced the second set, and he started to make improvements there. This was quite a useful graph for him because not only could he see his improvement, and the graph has a kind of drama to it, I think, but it helped him understand the nature of therapy. So we can have a conversation about, that fact that you kind of get better at what you specifically practice. And that helped him understand the importance of him thinking more about and helping me out more with identifying what the treatment targets should be for vocabulary set number 3, 4, 5, etc. So meaningful data collection, helpful. Along with that, I used a lot of audio recordings. In self-determination theory, authors and researchers contrast what they would call informational and controlling feedback. And in essence, informational feedback is the kind of feedback that doesn't make clients feel pressure that, let's say, the next time they say the word, they need to say it in a specific way, or they need to do a specific thing. Informational feedback is giving information that's behaviorally relevant. So instead of, for example, just saying, yes, that's right, being able to say something that, if we feel like we need to give feedback, is feedback related to why that was right. That's, you could say, that sounded great. I noticed that you did this time. Or if we make some suggestions about what to do next time. So informational rather than kind of more of the right and wrong feedback. In general, positive feedback that is autonomy supportive, right? So positive feedback that is not pressured, something like, good, that's just the way I wanted you to do it, right? We want to, when we give positive feedback, we somehow want people to interpret that feedback in the sense that they were the reason why they did it well, that they have abilities And authentic positive feedback, as I write here, tends to do that. In other words, positive feedback that is informational. When we look at studies, it seems that when people are given a choice about when to receive feedback, that they tend to ask for feedback after they've done something right, as opposed to when they've done something wrong, on average. And the references here, Wolf and Luthwaite in particular, from the motor learning literature, suggest that when people are given a choice over feedback, not only do they tend to ask for feedback when they've gotten things right, but that control over when to get feedback is associated with better motor learning and better motivation. Of course, at the very basic level, if clients are given the choice when to receive feedback, then they're less likely. That's an expression of autonomy, and so we're probably not going to be engaging in as much pressure and controlled feedback. I pretty much ask my patients if they would like feedback, or depending on the task, how often, a simple question like, how often would you like me to give you feedback? I don't know that there are any rules here. One could ask, do you want me to pretty much let you know when you're doing it right? Things like that. Okay, so now we'll talk about self-efficacy, again related to satisfying the need for competency. According to Alfred Bandura, the author of self-efficacy theory, we form our self-efficacy beliefs through 4 kinds of information or experiences. The primary way, number 1, mastery experience. If I have had success doing some task similar to the one I'm considering in the past, if I've been successful doing something like this in the past, well, or haven't been successful. In other words, our past successes and failures are probably the single most influential determiner of our self-efficacy beliefs. Also, vicarious experience. If I observe somebody who I deem like me in relevant ways, doing the task I'm considering successfully, then that's going to increase my confidence. For example, for a real concrete example, there's a big rock here in the room. If a 350-pound guy comes and lifts it, that won't necessarily make me feel more confident that I can lift it. But if someone my size comes and lifts that rock, well, they are like me in relevant ways, and so that will increase my confidence that I can do it. Verbal persuasion, I think I may have mentioned, Alfred Bandura considers this the weakest form of self-efficacy. When it works, it's usually because it comes from a very trusted source. And then finally, physiological and affective states. Our physical and emotional experiences will tend to color whether we feel confident that we can do something. If I'm feeling very weak and fatigued today, I might not believe that I can lift that rock, wherein if I'd gotten a good night's sleep and felt energetic, I might believe that I can lift it. My patients might believe they can hold a conversation with a close friend or family member, but not with a stranger, etc. Now, we have to, I think, particularly if we're in neuro rehab, we have to understand that deficit awareness will affect people's self-efficacy beliefs. We will see people who have poor deficit awareness, and so they may be overconfident in a sense that they can do something. And then, of course, the risk there is that they're going to be in for kind of a rude awakening. We also see the opposite in the sense that people really don't think they have as much ability as they have. And I actually see this fairly commonly in my patients with aphasia who do a pretty good job of communicating, but for whatever reason, they perceive themselves as having very little ability to communicate. And of course, that right there will affect their motivation for a lot of behavior. They are less likely to engage in social encounters because of their lack of confidence. They are more likely to interpret whatever brief failures they experience over the course of treatment as a confirmation of their lack of ability. So we want clients to have accurate deficit awareness because that helps them have accurate self-efficacy beliefs. If they're going to be skewed one way or another, it's always better for them to have slightly optimistic self-efficacy beliefs. We can assess self-efficacy. It's quite easy to do. We simply create a 0 to 10 or a 0 to 100 scale, and we make sure that our questions are about task-specific activities, that there's some context there if it's relevant, and there are some formal measures out there of self-efficacy, none that I think would really fit what we do, although I believe there is one self-efficacy assessment described in the literature for stuttering. But anyways, they're quite easy to make informally. I do it all the time. I do it informally at the spur of the moment, sometimes just as a way of encouraging conversation and exploration. In my sessions, I may ask somebody, how confident are you that you can do this? And they give me a rating, and I'll ask them to explain that rating, why it's that number. If I want them, as I've mentioned in the past, if I want them to talk more about their strengths, I'll ask them why that number and not a lower number. I've used self-efficacy ratings as goals, so that, for example, a patient will feel 9 out of 10 confident that they can hold a conversation with a stranger. So we can use these in quite flexible ways, and here is just an example from my book chapter of a self-efficacy measure for my patient related to his ability to do his home practice, what is sometimes called scheduling self-efficacy. And as you can see here, I broke it down by the different barriers that he had chosen when we were addressing this intention behavior gap. And what you see in the column here are the potential barriers, and he wrote down his confidence level with respect to those barriers. If we want to assess barriers and we want to get an idea for how much they're influencing someone's self-efficacy beliefs, we always want to first ask how confident they are when the barrier isn't there. And that's what I address here in the sense of when everything is going well. And you can see his confidence that he could do his home practice regularly was quite high when everything was fine. Of course, life is usually not like that. This also from my book chapter. I'm going to go over these points briefly. You've got the book chapter. You can see the tables yourself. With mastery experience, I think a lot of our traditional activities, such as setting short-term and achievable goals, giving people, setting things up, therapy up so people have an experience of success. I think still it has to be experience of success that is meaningful to them. In other words, meaningful in terms of the value. 2, meaningful in the sense that they did not perceive it as being super easy to begin with, and so accomplishing it is no real reflection on their abilities. And number 3, we want to be very careful that our patients don't interpret their success as being due to our skill. We want to shape and guide the conversation so they can reflect on how this is an expression of their ability. Along with mastery experiences, managing barriers, of course, because barriers are going to prevent people from experiencing success. Vicarious experience, I think this mostly relates to any type of group therapy. And there are 2 key things here, and one is that I do think we want to consider who we invite into the group, in the sense that we want someone who is a good model of recovery for the other individuals who maybe are more recent in terms of being in rehab. Point 2 is, though, we don't want super patients. We don't want people who made amazing recoveries. We want people who are examples of good, common, I would say, improvement. In other words, people who stuck with it, were patient, worked for a long time, had slow, gradual gains that added up to something meaningful, faced different challenges along the ways, and persisted. Those are, I think, the best models for our clients. Verbal persuasion. In general, I think we want to pull back from kind of knee-jerk praise. Praise can be controlling. Praise can be interpreted as approval from our patients. I think if we can move more towards informational feedback, helping people understand why this production was more accurate than their last one, let's say, that helps us get around that praise issue, approval, contingency. It's also good to give verbal feedback, encouragement that highlights people's self-regulatory efforts. And what we mean here is not whether the task was done correctly, but whether the person approached the task in the way we would like to see them do it. So they demonstrated some kind of pacing ability. They went slower. They were better at self-monitoring. These are all self-regulatory behaviors, are things that people generally feel that they are in control of. I am in control of how patient I am. I am in control of how much effort I put out. Occasionally, some of our patients are not so in control of these things. Usually our TBI patients with frontal lobe damage who oftentimes present with some impulsivity. But in general, by praising or giving feedback on things that are controllable, that will increase people's sense that they're doing well, that they have some ability here. Finally, physiological and affective experience. For me, this basically means helping my patients understand that their physical state, their level of energy, how much sleep they got the night before, their emotions, whether they're experiencing anxiety, and overall their stress level, very often will influence negatively their speech performance, their communication performance. And that's step one, is understanding that. And then step two is to help them not make the mistake of interpreting failures when they're in these less than ideal physiologic and affective states. Not to misinterpret that as being about what their ultimate abilities are like. Right? In other words, if I didn't sleep last night because I was ill or whatever, and I did poorly on a quiz this morning because, my concentration was shot. Well, I don't want to interpret that as meaning that I should drop out of school, that I can't do it, right? I mean, there's a reason there that is separate from what my abilities are. And I think this is very important because our patients don't make those connections oftentimes. Overall, the evidence on self-efficacy interventions is mixed. And I would say it's mixed for two reasons. Number one is, from a self-determination theory perspective, it's somewhat mixed because satisfying one basic psychological need is perhaps not enough to engender true autonomous motivation and all of its benefits in terms of engagement, deeper learning, etc. Number two is that many of these studies did not focus on all four sources of self-efficacy information and experience. It didn't address ensuring mastery experience, good vicarious experience, etc. There are studies out there which did make an effort to address all four sources of self-efficacy information, and when we look at those, their outcomes do seem to be stronger. Now we'll talk briefly about relatedness support. There is not a lot to say here because I think we're probably pretty good about this. And I guess one way to think about relatedness support is that in motivational interviewing, for example, they talk about the spirit of motivational interviewing and the different things that make up the spirit of motivational interviewing, one of them being compassion. And so I think that communicating relatedness support has to do with our mindset and our attitude as much or more than specific techniques that we use, like in autonomy support and competence support. So with relatedness support, it's more about being quite mindful about how we're presenting ourselves and connecting with our patients. And so we want to be careful that we show unconditional positive regard, meaning that our clear and communicated care for patients does not falter, does not depend on whether they behave the way we think they should, whether they did their home practice or not, whether they appear to be motivated or not. That we want to communicate genuine concern. I think that goes along with being honest and transparent with patients. It also goes along with really acknowledging when there's some conflict. If a patient, for example, is brought to therapy by their spouse, and you get the feeling that maybe they've been in therapy before, haven't really experienced much or any success. I get these clients every now and then. I think usually when we do something as simple as saying, I get the feeling you maybe don't really want to be here, and that maybe your wife is bringing you, and that maybe one of the reasons you don't want to be here is because you just haven't had a lot of success in the past. That kind of open acknowledgement is, I think, in general good for our relationship with our clients. Next slides just really give credence to the fact that a good therapeutic relationship will have a positive influence on outcomes, independent of what the therapy is we're doing, the kind of client we're seeing. In around 2000, the American Psychological Association put out a position statement. Organizations are usually pretty confident when they put out position statements. And they basically said, no matter what school of psychotherapy you subscribe to, whether you are engaged in Jungian therapy, Freudian, CBT, etc., no matter what the disorder you're treating, addiction, depression, whatever, no matter the age of your client, the quality of your relationship with that person will have a demonstrable impact on outcomes. This study, systematic meta-analysis from Lawton, just gives evidence to this. They found that having a good therapeutic alliance or relationship had a positive influence on motivation and engagement. Patients emphasized caring and being valued. They also, Lawson and colleagues, acknowledged that underlying the process of developing and maintaining a positive therapeutic alliance was an inherent power differential between the patient and professional. Despite professionals' efforts to redress the balance, disequilibrium remained dominant. I think that's true. No matter what we do, the situation is set up so that to support a more medical model of rehabilitation where we're the expert, we have the answers, we fix people, etc. I think that one of the best ways around this, and what wasn't addressed in this Lawton study, this meta-analysis, is that if we support autonomy, we're consciously engaged in autonomy support and competency support, I think this the issues surrounding this power imbalance and how it reinforces passivity in our patients is addressed to a large degree. And this is simply the remainder of that evidence demonstrating that a good relationship with our patients will tend to influence the value that patients place on therapy and how they interpret therapy. So I'm going to finish up this lecture by making some brief and general remarks about outcome expectations and goal setting. And first, I want to talk a little bit about hope. I think hope is something that many speech pathologists feel uncomfortable in terms of knowing how to navigate their patients' hopes. In general, I think therapists are concerned about giving people unrealistic hopes. The reason, I think, because they think that in doing so, that when those hopes don't come to pass, that their clients will have some kind of catastrophic psychological reaction. First, and Snyder has written about this, this fear of giving false hope is overblown. With few exceptions, people, particularly in rehab, will tend to adjust their hopes in their own time. In other words, we don't have to worry when someone comes in and starts therapy that they think that they're going to return to normal. If my patients ask me, can I get back to normal? I'm certainly not going to lie to them. And I will say, hypothetically, one could. I have never seen it in 20-some years of practice. That being said, I have had many patients who improved to the point where they were satisfied with their communication ability. And I think for me, I've found it very useful to do whatever I can to guide my patients away from thinking about performance, right? Like when we say I want to get back to where I was before my stroke, we're saying I want to perform the way I used to perform. If we can get our patients to focus more on getting to a point where they're satisfied with their communication, in the beginning that term might mean returning to normal for them. But I think focusing on satisfaction, there's a lot more wiggle room there. To say I want to return to what I was before the stroke, there's no wiggle room there. It's binary. You either make it or you don't make it. But getting to a point where I feel satisfied allows me to get 60, 70% towards normal and be a success. So I don't think in general that we need to worry too much about false hope. I have never had a patient complain to me that their previous therapist gave them too much hope, but I've had many, many patients complain to me that their previous therapist squashed their hopes. In other words, told them, you're not going to get a lot better. Felicity Bright has looked at hope in the context of aphasia and said that for stroke survivors, hope is a source of motivation. It's something that we can contrast with goals. Goals are quite specific. Hope tends to be a general kind of idealized future, expectation for some general better future. It seems that during rehab, when people are struggling to meet their goals, they fall back on hope. And so hope serves as a kind of buffer against despair. Looking in the literature, the rehab literature, you see a fair amount of differing views on how much hope to give people and the dangers of that. I certainly don't think that we should promote unrealistic expectations. Part of the art here is helping people move to more sober expectations that also preserve their hope. So I may have mentioned in the past in class, when I give at the beginning of my relationship with the patient, I often, when they ask me how much better can I get, I often give them kind of my good news, bad news speech. The good news being that you can continue to improve your speech, and there is apparently no end to how much improvement you could make, in the sense that people don't really, with few exceptions, people don't really plateau. They just stop working on improving their speech. So it doesn't matter how long it's been since your stroke. It could be 20 years ago. It doesn't matter how old you are. You can still improve your speech. That's the good news. The bad news is that the effects of treatment are slow and gradual. And so many people struggle because they don't have a real tangible experience that they're improving. And we need to understand that so we can understand what's going on. Also, the effects of treatment are more or less item specific. So that's very sobering, because let's say if you have a word finding difficulty, most adults have a vocabulary of 20, 30,000 or more words. And so if we're going to be working on regaining access to words, and we do that 50 words at a time, some therapists do a lot less, 20 words at a time, it becomes clear that we're not going to be able to get through all 20,000. And so we have to choose these words very carefully. When I give that good news, bad news speech, what I notice is that people want to hear just the good part, that they won't plateau. And they kind of don't hear the part about item-specific treatments. And so that's something I have to continue to educate them about. Some people have, and I agree, stated that overall we want to give some slightly optimistic expectations to patients. Finally, I think that satisfying people's basic psychological needs tends to help people come to more realistic perspectives more quickly, in a way that is not disruptive to our relationship with them. So in general, I think when we do that, this naturally unfolding kind of move towards more realistic expectations and a focus on seeing the glasses half full rather than half empty is certainly promoted by needs support. Finally, a few thoughts about goal setting. Goal setting as a whole, the huge topic by itself, so I'm going to highlight some motivational issues around goal setting. The first of which is to understand that goals have characteristics, and these characteristics will have been described as having an influence on motivation. This illustration you see here, most of this coming from Locke and Latham's goal-setting theory, saying that, for example, proximal or short-term goals tend to be more motivating than long-term goals. I will sometimes or often set informal short-term goals for my clients. I see my clients once a week, so I might say, well, with regards to what we're working on, what would you like to achieve by next week? That gives them really something to have, maybe a sense that they're accomplishing something every week. And for many of my patients, that's very motivating. Of course, the expectations of whether they'll meet the goal, the outcome expectancies, that nature of the goal will influence motivation. How much a person values the goal. Again, we said that in general, challenging goals that are doable are most motivating. Learning versus performance goals. A performance goal is, I'm going to achieve a very specific objective level of performance. Those are fine. We have to do those. I think we can realize that we can also add learning goals, which are a little bit more motivation friendly, in the sense that in general people always feel like they succeed in this respect. So a learning goal might be something like it could be something as simple as, I will understand this strategy that's being recommended to me. Or it can be more like a self-regulatory goal. I will monitor my speech and catch a higher percentage of my errors. Specific versus vague goals. In general, more specific goals are better than kind of do your best goals. Intrinsic versus extrinsic goals I'm going to talk about right now, because that is more coming from the self-determination perspective. An intrinsic goal is, the term here is a bit confusing. We're not really talking about intrinsic motivation in a sense. We're talking about intrinsic motives, intrinsic reasons, intrinsic goals. So intrinsic goals have been described as reasons which, in general, tend to be about self-development, tend to be about being healthier or maintaining health, tend to involve more social connectedness. I would also add in here, they tend to be virtuous in the sense that they might be about helping others. Whereas extrinsic goals are more about gaining material success, about achieving status in the eyes of others, and this can include being a good patient. So as you can imagine, goals that are more intrinsic tend to be more motivating in the long run. And so this leads to a practice called goal framing. And goal framing is when either the clinician, or ideally the patient, talks about why a goal is important. And in doing so, focuses on those intrinsically beneficial elements, right? Working on, improving my word finding is a good goal because it'll help me maintain my social bonds with others, help me make new friends. Right? There's some examples of intrinsic reasons rather than, an extrinsic reason would be maybe something, I'm trying to think of something I hear, something to do with kind of status and protecting oneself from embarrassment. Clearly that's a motivating reason. The problem is it's probably not a real sustaining motivating reason. So using counseling techniques, we can guide people to talk about why a goal is important to them. So the first question is okay, here's the goal. Tell me why this is important to you. And then listening to what they say, using open-ended questions to continue to guide the conversation, reflective listening to get them to elaborate on something that they said that highlights the intrinsic nature of the goal. We also, I think, in the course of goal framing, want to help people connect these short-term goals to their long-term life goals, because those life goals are often more of the intrinsic goals. And finally, I think we want to pay attention to whether what we're hearing from our patients are reasons that maybe other people have, and sometimes people will flat out say, because my wife wants me to, blank. Or whether we think that we're hearing kind of should-like goals. I should be better at this, I should be better at that. Implementation plans. So when we talk about goal framing, we're talking about exploring the what, the content of a goal. An implementation plan has been shown to help people pursue goals because, again, our patients can do goal framing, can elaborate on all the intrinsic reasons why they want to pursue a goal, and still find themselves in that intention behavior gap. And so we might have to add, an exploration of barriers to achieving the goal, and how to come up with strategies to manage those barriers. And then simply outlining what is sometimes called an action plan, which is, here's the goal, this is what I'm going to do and when in order to achieve that goal. And implementation plans in some meta-analyses have had a strong impact on goal pursuit, goal persistence. In the self-determination theory literature, Kostner and colleagues did 3 studies and a meta-analysis showing that overall autonomous motivation was associated with good goal progress, and that it was even more, autonomous motivation was even more associated with good goal progress when there was some overt implementation plans drawn up or discussed. Okay, that is it for our motivation lectures.